Welcome back to the part 3 and the final part of our seminar. The regeneration. This includes the guided tissue regeneration and bone graft. The guided tissue regeneration, as it was discussed in the regeneration seminar a couple days ago, it's a barrier membrane that is adapted to fit over the defect and the root of the tooth in order to guide the fibroblast cell of the periodontal ligament to contact the root surface during healing and prevent other cells of oral epithelium like gingival connective tissue and epithelial cells from contacting the root surface so as to lead for the new connective tissue attachment. It is best for the class 2 involvement and the membrane that is used either non-resorbable membrane or resorbable membrane. We have different types of membrane. The methylcellulose acetate like Millipore, Bedford, M8 and USA were successfully used in the first guided tissue regeneration cases. But however, those membrane, because of being fragile and shear easily, so they were replaced with a Gore-Tex. Gore-Tex or polytetraphenyl membrane can selectively exclude the migration of epithelial and gingival connective tissue cells and integrate with bone and connective tissue margin of the periodontal defect. This material not only possesses adequate stiffness to allow creation and maintenance of secluded space into which the new attachment will form, but also is supple enough to allow adequate adaptation over the defect. We have different types, configurations and sizes. Some of them are non-reinforced, some titanium reinforced configurations. The titanium reinforced configuration are specially indicated when the defect anatomy is not supportive, such as in one wall defect. So we need additional support, that's why we use the titanium reinforced. Disadvantage of their use is the high frequency of eerily spontaneous exposure to the oral environment and the need to be removed after 6 to 8 weeks in the second surgical procedure. The bioabsorbable membrane, including collagen, also polylactic acid, like the Adsorb, which either comes in blocks or it could be injected. Surgical procedure. First, we're starting, of course, after the giving local anesthesia, we are starting with the incision. Incision starting intracellularly to reflect a full mucoperiosteal flap. Then all residual pocket epithelium is removed to permit integration between the membrane and the flap connective tissue. Incision should extend about 1 to 2 teeth, mesially or distally, to permit adequate visualization and then closure of the wound. Vertical incision only indicated when necessary. Scaling and root planing to remove all diseased tissue. Decoration of the bone for increasing vascularity and scratching of the periodontal ligament to stimulate the cell and vascular proliferation. The placement of the suitable membrane. We should maintain sterility of the material while we are handling it, and we should choose the appropriate size and shape that will cover the defected area. We shouldn't use too much size so that it will be exposed from the wound, and we shouldn't be using the very small size that it won't be easily to be sutured in place. Shape of the material with scissor to avoid sharp edges must be rounded as much as possible. Leave enough material to permit suturing, and then the material should be fit smoothly and avoiding the folds, overlaps, or protrusions which may interfere with the overlying gingival tissue. Sling suture is used to approximate the material over the defect without engaging flap or tissue in any way. And then the material must fit tightly against the tooth surface at all points. This is to perform its function in prevention of the gingival cells, epithelial or connective tissue cells from migrating over the root surface during healing, and only allow for the periodontal ligament cells to be there. The flap margin should ideally be 2 to 3 mm coronal to the material, and then tight flap position is desired to avoid premature flap opening and the material exposure. Removal should be within 4 to 8 weeks after placement. The material cannot be removed. If the material cannot be removed with gentle tag, then a sharp dissector is recommended. We must be very careful to avoid damaging the underlying and the new granulation tissue. And a small tissue forceps is used to remove the material carefully. The flap is then reapproximated over the new tissue and sutured with silk suture. Postoperative considerations. Verdex mouthwash is recommended for the 10 days, and if the material becomes exposed, then it should be used until removal. Antibiotic cover for 7 to 10 days. Use of periodontal dressing is optional. Flossing at the treatment site should be avoided in order not to interfere with the healing process and not to damage the placed membrane. The patient should be seen biweekly if there is no exposure and weekly if exposure is present. The material should be removed immediately if any complication developed. The use of Imdogen. Imdogen is a mixture of enamel matrix protein that is applied to clean tooth-root surface or oral wound. Form an extracellular matrix that stimulates cells and processes that are fundamental for periodontal regeneration. Indicated for grade 2 and 3 furcation defect. Here we have 55-year-old female patient with grade 2 furcation defect in the lower first and second molars. After throat scaling and root planing, the decision was to perform surgical procedure using the Imdogen. Starting the procedure following local anesthesia with the intraclavicular incision using 15C blade, like we see here. The same incision is done lingually. Flap is reflected both buccally and lingually. Granulation tissue removed with curate and any bacterial deposit must be cleaned. Prep gel for 2 minutes for smear layer removal. Application on the second and first molar area. Here we can see the flap is handled with sutures for better visualization and best suturing then of the flap. Rinsing with sterilized saline solution, and then Imdogen application. After that, suturing and application of the remaining Imdogen over the suture, which could improve the healing process. Now the bone graft. We have different types of bone grafts. It could be autogenous bone graft, allograft, xenografts, and alloplastic materials like hydroxyapatite and tricalcium phosphate. Maxillary facial class 2 furcation defect. In the picture A here we have in the maxillary first molar, there is a class 2 furcation defect and 6 mm focal depth. After full thickness flap elevation from the buccal and palatal aspects, debridement with curate, rotary instruments and ultrasonic scalars, a freeze-dried bone allograft was adapted and condensed to the site overlying the furcation defect and root dehiscence. A collagen barrier is then placed and extend 3 mm beyond the defect and adapted to tooth, and the flap and barrier were sutured together to stabilize. This is a 2 and 4 follow-up periods. Here we can see we have only 2 mm depth from the original 6, and this is after 4 years, which is a nice result. Now the decision of extractions. Extraction is indicated when we have advanced class 3 and 4, that it cannot be treated. We have advanced attachment loss, adequate plaque control, non-compliant patient, high caries activity, and socioeconomic factors when the patient cannot afford for the cost of other types of procedures, so the decision could be extraction. And now the prognosis. Grade 1 and 2 have good prognosis. The grade 3 early stage has fair prognosis. Grade 3 advanced and grade 4 have poor prognosis. Also, prognosis is poor for short tapered roots and relatively large crowns. As I mentioned in the beginning of the seminar, when we have short roots, it means when the furcation is involved, most of the periodontal support for the tooth is lost. So the prognosis and outcome of the treatment will be poor. Prognosis for individual teeth depends on. It depends, of course, on the morphology and anatomy of the tooth and root, morphology of the bone deformity, crown-root ratio, mobility, patient's age and general health, and therapist knowledge and skill. Finally, the conclusion. We should put it in our mind when we are dealing with a furcation defect. It requires knowledge of the anatomy and the problem associated with the furcation, and the keys for successful treatment, including those from the side of the patient and those from the side of the dentist. So early diagnosis, thorough treatment planning, good oral hygiene by the patient, and careful technical execution of the therapeutic modality and a well-designed program for periodontal maintenance are very important. Grateful for your time.